Chancre redux typically is the name which is given for which important infection? Of course, after HIV has become got into the top of the list of sexually transmitted diseases, Chancre has little disappointed and it has gone back. But still some questions come on syphilis, doctor, a very important topic, especially serology of the syphilis, VDRL, all these things you have to thoroughly revise, which we already discussed. So, a second chancre which will be typically occurring in a syphilitic subject, while still the first infection is continuing, is typically called as the chancre redux. Chancre redux is also thought to be predominantly an allergic reaction. That's the reason, though the specific spirochete is absent, still the reaction can occur, which is called as the chancre redux, is what I want to underscore to all of you. Now let's go to the next question. Max Joseph space is typical histopathologic feature of which important condition? Always the rule of the entrance is topics are same, but the kinds of questions generated are little atypical. That's the only thing. So if you take this topic called lichen planus, it is a stock topic. But the presence of the Max Joseph space as a histopathological feature is something which is a newer question. So basically, what are the important sites where there is a predilection for the lichen planus? The wrist, shin, ankle and the sacral region in the mouth and genitals are the common location. Typically, how do you describe the lichen planus lesions, doctor? They are the polygonal papular lesions which are pink in color, associated with the pruritus is the classical description. Now if you take the lichen planus, you have got a hypertrophic variety, there is a bullous variety, a linear variety, like that various varieties are there, and nail manifestations of the lichen planus is another favorite topic of the examiner. So nail dystrophy can also be associated. Now let us ask Dr. Vineet as a today's target. Doctor, what is this classical finding dermatologically you are seeing in this given case of lichen planus? Let us say I already gave you the clue that it is a lichen planus. What is this phenomena? Cognous phenomena, where at the point of the trauma there is a generation of a new lesion, is classically called the cognous phenomena, is what need to be remembered. Similarly, those polygonal, flat and shiny papules of the lichen planus are unforgettable. One of the common clinical vignette in dermatology given in the entrance exam is when an individual presents with this kind of description of the lesions. Now comes our exact question. What are these Max Joseph spaces is my question to all of you. Typically, if you take the biopsy of the skin, you have got epidermis and dermis and subepidermal space. Typically, the artificial subepidermal clefts which become generated in a given case of the lichen rubor are typically called as the Max Joseph space, which are seen in the vesicular variety of the lichen planus, is what I want to once more underscore to all of you. Now once more, this is a classical spotter for all of you. What are these typical lazy network-like lesions which are seeing in the mouth, doctor, which are white network-like lesions called Wickham's striae, is something which is unforgettable. Now anyway, we raise the topic of lichen. Quickly let us review few classical points which are often the questions in the entrance. What is this lichen rubor planus is my question to all of you. Typically there will be a lot of hyperkeratosis without parakeratosis on dermatopathology, and there will be a band like inflammatory lymphocytic infiltrate along the upper dermis in a given case of the lichen planus if you happen to clinically, histologically check it. Why are you interested as a histopathologist about the lichen planus? A small child had been taken to n number of doctors because he was having a lot of pruritus. And every time there is a scratch, once more another lesion which is papular in nature is growing up. Typical history of Koebner's phenomena. And he was thought to be a case of scabies by most of the doctors. And incidentally he reached you and you are the expert dermatologist in that particular city. With the proper history and clinical examination, you thought that this is not scabies, though it is pruritic and it is papular, it could be lichen planus. Want to check suspicion, then histopathology will help you where a dense band-like inflammatory lymphocytic infiltrate in the upper dermis is the one which gives the clue for you that it is a case of the lichen rubor, is what I want to once more underscore to all of you. So these are all the typical lesions of the lichen lesions, which are also papular here, but the papules are very hyperkeratotic in nature. So this is otherwise called a verrucous or a hyperkeratotic variant of the lichen planus is what I want to underscore to all of you. You have hyperpigmented brownish red variant like lesions. Once more, pruritus is the symptom. But why are you worried about this hyperkeratotic variant of the lichen planus is my question to all of you. Because this important variant of the lichen planus is a harbinger of a future squamous cell carcinoma. So that is the reason you are worried about this hyperkeratotic variant is what you need to basically understand. Another important variety of the lichen is called the lichen planopilaris is another important variant. Here there will be a lot of perifollicular infiltration that will be there, and the lichen planopilaris is the one you need to remember because scarring alopecia is one of the important complications of this important condition. That's the reason you are very much worried about. So now you are encyclopedic about lichen, doctor. Today only you revise it because this is one topic which is going to come in tomorrow's exam. Ivermectin typically is indicated in the treatment of which important infection? Scabies, lot of agents are used in scabies. The oral ivermectin is a very affordable solution which is available for you, and typically whenever there is a severely crusted scabies, which is not uncommon in an immunocompromised individual. For example, if a patient is on steroids, he is immunocompromised. Similarly, HIV individual, post-renal transplant, a lot of scabies is highly prevalent in him in that scenario. Similarly, when the topical therapy with the scabies happen to fail, in that scenario, oral ivermectin is considered to be the treatment of choice. At least as a primary physician, doctor, after passing out MBBS, you must be doubly sure about managing a case of scabies. That's what the community expects you, though you are a plastic surgeon, though you are a surgeon or a physician. So what are the scabicidal solutions which are available for you, which you can use topically? Lindane, permethrin cream and crotometone lotion, these are the three important scabicidal solutions is what I want to underscore to all of you. Let's go to the next question. Erythema nodosum leprosum is a very important reaction in the leprosy, all of you know very well. Once more I like to emphasize to you, doctor, leprosy, tuberculosis, malaria. Without them there is no question paper, hence you have to make a revision in the last moment. Now, what is the cause for the development of this erythema nodosum leprosum is my question to all of you. But before that, let us have some amount of commonly asked issues about the lepra reactions. Are there any precipitating factors for the development of the lepra reactions, especially erythema nodosum leprosum is my question to all of you. Please remember, doctor, surgical operation, pregnancy, parturition, lactation, menstruation, trauma, and the vaccination and sometimes the treatment itself can be one of the important precipitating factor is what I want to underscore to all of you. Similarly, for some reason you have given an iodide or a bromide to the patient that can also precipitate erythema nodosum leprosum. Let us say you have a patient with leprosy with thyroid problem. So for thyroid, if you happen to give iodide, there is a chance of precipitation of the erythema nodosum leprosum. Now, in a given case of the erythema nodosum leprosum, basically, there is a very high bacteriological load. And whenever you have initiated the treatment, all these bacteria are dying and they are releasing a lot of antigen load. And because of that antigen, there is an immune complex formation. In turn, this immune complexes will stimulate the tumor necrosis factor and the vasculitic reaction, which is the underlying pathophysiology in the case of the erythema nodosum leprosum is what I want to once more underscore to all of you. Typically what you are seeing here is on the trunk, there are a lot of pustular necrotic lesions which are typical of the erythema nodosum leprosum. So a patient of erythema nodosum leprosum is typically the one who has got a very high bacterial load is what you need to fundamentally understand. Let's go to the next question. Once more you can see how important is the topic of leprosy in this subcontinent of India if you want to become a physician here. So type 2 Lepre reaction, what is the treatment of choice is the question, and which drug especially you should not use which can bring a flare up in a given case of type 2 Lepre reaction. So basically, if you take the erythema nodosum leprosum, there are two things which are very clearly discernible. Is there a involvement of the nerve or the skin or both of them in the case of the erythema nodosum leprosum is my question to all of you. So please remember, doctor, there will be a lot of peripheral nerve involvement. That's the reason there is a claw hand and a foot drop. Usually it is the vasculitis involving the nerve trunk which is the major problem in the erythema nodosum leprosum. In addition to that, because of the serum sickness like reaction precipitated by all those immune complexes of the erythema nodosum leprosum, patients can develop arthritis, edema, orchitis, lymphadenopathy, iridocyclitis. They all can be associated features with the erythema nodosum leprosum. Now the WHO has given certain guidelines for the management of the erythema nodosum leprosum, do's and don'ts about it. Now you are going to be the master of this topic because one of the favorite topic of the examiner. Suppose if the patient is receiving anti-leprosy treatment and he has developed erythema nodosum leprosum, what do you want to do? Clinical scenario number 1 which is given to you. Continue the standard course of the multi-drug therapy is a very important rule. It is not an indication for discontinuation of the MDT. If the MDT is already completed, it need not be restarted, and try to give adequate amount of analgesics which will take care of fever and pain. And there is an indication for corticosteroids in the management of ENL reaction. So you need to give prednisolone at a dosage not exceeding 1 milligram per kg per day. That is a 50 kg individual, you can give at most 50 milligrams of prednisolone for a total of 12 weeks is considered to be the treatment of choice. Suppose if the patient with ENL whose disease is not responding to the treatment with the corticosteroids, or if he has got any complication, for example he is a diabetic, you can't afford to give 50 milligrams of prednisolone for 12 weeks. Then in that scenario, what is the treatment of choice? Clofazimine and a little lower dose of the corticosteroids is considered to be a very good combination. Clofazimine 100 milligrams twice daily for a maximum of about 12 weeks along with the prednisolone is considered to be the treatment of choice, and slowly taper down the clofazimine dose to about 100 milligrams twice a day and then 100 milligram once a day between 12 to 24 weeks. That is considered to be essential part of the management. Similarly, if the patient has got a severe ENL and the corticosteroids are contraindicated, then clofazimine alone would also be sufficient. But in this case, a high dose clofazimine for about 12 months is considered to be the treatment of choice is what I want to underscore to all of you. But what is the limitation of administering the clofazimine in an acute scenario where the patient is having ENL, and how prednisolone is one upman over that of the clofazimine is my question to all of you. Clofazimine will take nearly about 4 to 6 weeks of time for it to make the start of the game. So that lag over period you must be ready and prepared. That's an important limitation. Another important drug is pentoxifylline also. Either alone or combined with clofazimine and prednisolone can be given is what I want to underscore to all of you. Now, thalidomide in the management of the ENL. If it is a female patient, absolutely there is a contraindication. You don't know during the long-term course when she will become pregnant, and teratogenic effects are really very severe and morbid. There's a reason, doctor, thalidomide had been removed from the first line management of the leprosy is a very important role is what I want to underscore to all of you. But if I ask you a question, if thalidomide need to be administered for ENL, then what are the indications? Number one, if he is a male patient. So in a male patient you can do that, but whenever you initiate you must be doubly sure to taper it slowly or to discontinue the drug is a very, very important rule. Now what are the other choices where lot of immune complexes which are forming in a ENL patient can be purged out from the body and you can bring down the vasculitic reaction is the next important less tested therapies for the ENL reaction. Intravenous methylprednisolone, plasma exchange, intravenous immunoglobulin, cyclosporin and pentoxifylline and immunotherapy, they are all considered to be the part of the management is what I want to underscore to all of you. So finally, what is your answer, doctor? Thalidomide, cyclosporin, corticosteroids, all of them can be used, but not the chloroquine. In the case of the ENL, at the end of all this story you are able to remember. Today only you are going to revise the topic of type 1 and type 2 leper reaction in Harrison's internal medicine. Let's go to the next question. Which test is not used for the diagnosis of leprosy? All of you know lepromin test cannot be used because if it is a patient who has got, in the case of lepromatous versus tuberculoid leprosy, the two important extremities, lepromin test may be negative, still the patient can have leprosy. That's the reason lepromin test cannot be used in the diagnosis, is the golden rule, all of you know very well. But still, there is a small hitch here. Do we use fine needle aspiration cytology, slit skin smear and skin biopsy in the diagnosis of the leprosy is an important question to you. Very much we use. The skin biopsy which we do in a given case of the leprosy need to take into account the dermis and also the epidermis, and typically if there is a lesion, it is from the edge, not from the center of the lesion. From there you need to take the smear is another important rule which you should not basically forget. Similarly, for the proper classification of the leprosy also, skin biopsy is going to be the gold standard, is another important rule. Skin smears can be checked for the presence of the AFB by using the Gill-Nielsen technique with only 1% acid alcohol is a very important rule. Now, in reference to the microbiology of the leprosy, you must know what is the meaning of a bacillary index. Typically, it is 6 to 10 stain smears are observed with 100 magnification, and typically it is the logarithmic scale on which the reports are being generated. 1 plus bacillary load means to say if you are able to see about 1 to 10 bacilli in 100 fields, 2 plus is 1 to 10 bacilli in 10 fields, and 3 plus is 1 to 10 bacilli in every field, 4 plus is 10 to 100 bacilli in every field, 5 plus is 100 into 1000 bacilli in every field. So that way you need to basically remember, doctor, what is the way to interpret the bacillary load in terms of 1 plus, 2 plus, 3 plus and on. Similarly, if you want to be very sure the bacilli which you are seeing is a dead bacillus or a live bacillus, there are some specific tests for the viable organism called the bioluminescent technology and LAMA. It is not left against medical advice. It is laser microphobe mass analysis and fluorescent diacetate ethidium bromide staining. They are all considered to be the various techniques is what I want to underscore to all of you. So finally, even FNAC is also used in the classification of the leprosy is another important rule. Finally, what you don't use for diagnosis would be the lepromin test is what you need to fundamentally remember. Let's quickly go to the next question. Airborne contact dermatitis can be diagnosed by which test? Nearly about 8 years back when I wrote the JIPMER entrance also a similar question, and after coming out of exam hall, they were all fighting, is it prick test or patch test? So there's a reason, doctor, questions are same, only thing is answers are different and aspirants are different. So please remember, patch testing is basically for all those external chemicals to which the person is allergic. So there's a reason, doctor, if it is the airborne contact dermatitis, it is the patch test which is considered to be a very important test in the diagnosis is what need to be remembered, because it is very cost effective is what you need to understand. Certain chemicals like neomycin is one important thing. It is little atypical among the various allergens in turning positive for the patch test. What is the reason? If the individual is allergic to neomycin, then patch test can be delayed positive. So that important exception you need to remember. Similarly, for elderly patients, if you compare with the younger patients, in both of them, the patch test is going to be little later manifesting positive is what need to be remembered. One more important thing is, if the patient is receiving prednisolone for whatever be the reason, there if you are suspecting allergic dermatitis, there the patch test is not going to be useful is another important exception that should not be forgotten. And another important question is, suppose if the patient is using antihistaminics because he is having an acute allergic episode, that time you want to do patch test. Can you do that while the patient is receiving antihistaminics? Still you can do, though the patient is taking antihistaminics is what need to be understood. Then where do you use the prick test is the next important question. It is for the contact urticaria, whereas the patch test is for the allergic dermatitis you have to be doubly sure about. Now let's go to the next question. Supracondylar fracture of the humerus, typically malunion leads to which important abnormality? Already we discussed about orthopedics previous questions past 7 years. At least more than a dozen times there was a question on supracondylar fracture which you are going to revise today itself. So there is a reason there can be a cubitus valgus deformity which can occur is what need to be remembered. If you look at the supracondylar fracture, if you look at the trochlea will be resting at about 6 to 8 degrees of valgus compared to that of the humeral shaft in the case of the normal supracondylar anatomy is what need to be remembered. In relation to the radiology of the supracondylar fracture of the humerus, you need to know few important landmark terminology. What do you mean by Bowman's angle in relation to the supracondylar fracture of the humerus? Typically it is the line which is perpendicular to the humeral shaft and the line parallel to the lateral condyle. If you draw, the angle between these two is called the Bowman's angle, which is important in the case of supracondylar fracture of the humerus. Similarly, the angle between the intersection of the long axis of the humeral shaft and the medial epicondylar growth plate, which is about 34 to 42 degrees, is another important angle that need to be remembered. Finally, there is another important angle called humerotrochlear angle, which is also important between the longitudinal drawn along the shaft of the humerus and the axis of the condyles, the angle. So these three angles in relation to the supracondylar fracture. What is supracondylar fracture basically? You can appreciate here, doctor, there are something called condyles, and above that level this area is called supracondylar. So here you are able to see clearly that how a supracondylar fracture radiologically will be looking at. Now if this fracture is not timely united or taken care, it can lead to a severe amount of cubitus valgus deformity, which can be one of the important complications. Then what is the type of reduction procedure you want to do for a supracondylar fracture? Typically close reduction with a percutaneous pinning is considered to be the treatment in the case of a displaced supracondylar fracture is what need to be remembered. And angular deformities, if it is excessively displaced, then the cubitus varus can occur, but generally cubitus valgus is more common is what need to be remembered, and because of that there is a loss of extension. And also there is a tardy ulnar nerve palsy which will be developing as the late complications. Now let's go to the next question. A 30-year-old with the numbness of both the lower limbs and the right upper limb, and the blood pressure is 160 by 110, and there is a distal gangrene involving the second and third finger, and the microscopic examination is showing the RBCs, whereas the urea and creatinine, that is the serum biochemistry, is within the normal limits. And what is your diagnosis? First I like to ask you a question. The patient is having classically the presence of the gangrene and a numbness in the lower limbs and right upper limb. Now let us ask, Dr. Raghuram will be our consultant today. How do you explain, doctor, such a varied manifestations of paresthesias on one side and gangrene on the other side? Vasculitic pathology is what is going to be on the top of your diagnostic list. So the patient is basically having vasculitis. So malignant hypertension, is it a vasculitic condition? It involves the vessel with a fibrinoid necrosis, but it can't be called as a classical vasculitis. Then what are the vasculitis which are available for you? In the options given, you have polyarteritis nodosa, Church-Strauss syndrome, and systemic lupus erythematosus. All the three can lead to the development of vasculitis. Now the challenge before you is, which vasculitis typically will have gangrene and also the presence of the paresthesia, where the vasa vasorum of all those nerve trunks are of the sensory nerves are the ones which have become vasculitic, and because of that there is an ischemia to those sensory nerve trunks. That is the reason there is a development of sensory symptoms of the paresthesia, which can be explained by the vasculitis involving the vasa vasorum with the ischemia. So on one side there is a vasa vasorum, at the same time there is also another major vessel going to the lower limb, that is also the one which is getting involved. So basically whenever you are having a case of vasculitis clinically, you have to check for, is this the vasculitis of the small vessels, medium sized vessels, or the large vessels? Accordingly, the classification will depend upon. So now let us talk about it. Polyarteritis nodosa is one of the very important vasculitic condition which you should not forget. Typically the patients will be acutely ill. They show malaise, fever, weight loss, and outside before reaching you, the primary physician would have treated him as a case of tuberculosis with anti-tubercular therapy. Because weight loss is their possible malignancy. Different diagnoses were placed on his discharge summary. Every hospital he was shifted one from the other. Finally he reached you, and you are the eminent rheumatologist of the city. Now, what is the other features you are looking forward in this patient? There is a peripheral neuropathy with the GI and cutaneous involvement associated with the malaise, fever and weight loss must give you a high index of suspicion of a possible vasculitis in the given case. So typically this is the angiogram of the celiac axis. Some of you are going to be the future interventional radiologists. What you can see here, doctor, is this aneurysmal dilatation because of this vasculitis is a classical feature in the case of the polyarteritis nodosa, is something which you should not basically forget. Peripheral neuropathy will be of a mononeuritis multiplex variety, and musculoskeletal features can be an asymmetric polyarthritis because of the vasculitis. And if you happen to take that vessel and do the biopsy and look through the microscope, there will be a development of a fibrinoid necrosis which is involving the intima and media of this muscular artery, is a very classical feature. Now the question is, what is the difference between the vasculitis of the giant cell arteritis versus that of the vasculitis of the polyarteritis nodosa is one of the common question on which pathologists will be fighting in a clinico-pathological conference. Now you have to be doubly sure. Typically, in the case of the giant cell arteritis, if you look at the vasculitis of the vessel, there is a granuloma formation. So it is a granulomatous vasculitis is what you see in the case of the giant cell arteritis, whereas it is a non-granulomatous vasculitis is what you see in the case of the polyarteritis nodosa, is what I want to underscore to all of you. Similarly, in polyarteritis nodosa, there can be a renal involvement in about 30 to 60% of patients. And the type of involvement is called vascular nephropathy, is what I want to underscore to all of you. Now there is a very close entity who is like the twin brother of the polyarteritis nodosa, which you need to know. It is called microscopic polyangiitis, MPA. What is the single most important difference between the microscopic polyangiitis renal involvement versus that of the polyarteritis nodosa? In one of the recent entrance discussions we had, one of the favorite question of the examiner. Both involve the kidney, but the microscopic polyangiitis leads to glomerulonephritis. That's the reason hematuria, hypertension, smoky urine, all these features will be seen in the case of the microscopic polyangiitis. But you don't find such a glomerulonephritic picture in the case of the renal involvement of the polyarteritis nodosa, is what you have to clearly understand. So what kind of involvement do you see? The same vasculitis will be involving the renal vessel. So renal vessel becomes stenosed. Hence renovascular hypertension is the renal manifestation of the polyarteritis nodosa, whereas the glomerulonephritis is the renal manifestation of the microscopic polyangiitis. The fundamental difference between these two you have to be doubly sure about. The renal arteries will suffer from a necrotizing arteritis in the polyarteritis nodosa, and there is a development of thrombus within that necrosed vessel, and that leads to development of a renal infarction with a severe costophrenic angle pain with the tenderness in a given patient with polyarteritis nodosa. Similarly, if you happen to do the renal angiogram in a given case of the polyarteritis nodosa, you find lot of microaneurysms which will be seen in the polyarteritis nodosa. Finally, the patient will be developing the chronic renal failure over a period of about several months, because this vasculitis, ischemia with the development of hypoxia with the fibrosis leads to development of renal scarring, leads to development of the chronic renal failure with the end stage renal disease at a point of time, unless you have diagnosed it very early. So this is all the story about the polyarteritis nodosa. So quickly summarize, doctor, what you see in the case of the polyarteritis nodosa. The peripheral neuropathy with the musculoskeletal manifestations with the GI involvement, celiac axis, you are able to see the aneurysm, and the cutaneous involvement with the renal involvement in the form of the vasculopathy is what you are going to typically see in the case of polyarteritis nodosa. Then another important type of vasculitis is called the Church-Strauss syndrome, otherwise called allergic granulomatosis, and angiitis is another important type of vasculitis. Once more, one vasculitis differs from the other in two important aspects. Number one, is it medium sized, small sized or a big sized vessel, or all the three types? And which organ is it involving and what type of involvement is it having? That is the algorithm by which you will be approaching your final diagnosis in a given case of vasculitis. So Church-Strauss involves the small to medium sized vessel, and there are three important distinct features the way the Church-Strauss vasculitis will be evolving clinically. Initially, patient comes like an asthma case with a lot of eosinophilic involvement, like an asthma. Lot of pulmonologists have treated him with a lot of bronchodilators, and relentless asthma like presentation is there. Later on, he will be developing a lot of eosinophilia in the blood with the eosinophilic tissue infiltration, and later on there will be a lot of infiltrates appearing on the radiograph, and people thought probably this is a case of Loeffler syndrome. Another important differential diagnosis for this Church-Strauss vasculitis. Finally, there is a vasculitic phase, and the heart is the predominant and the most frequent site which is involved in the Church-Strauss vasculitis. Later on, lung, CNS, kidney, lymph nodes become involved, and finally the skin also become involved in the vasculitic phenomena. This is how the Church-Strauss vasculitis become involved. So lung and heart are predominant sites which are bitten by the Church-Strauss vasculitis, whereas the nerves are the ones and the kidney are the major things which are bitten by the polyarteritis nodosa. This important difference is what you have to basically appreciate. Now I will give you a short case presentation. A 35-year-old woman has presented with a 15-day history of gangrene of the fingertip of the left hand and the weakness of the wrist joint and the ankle joint. Now take up this topic, doctor. What is the type of story based on this 35-year-old young lady you are suspecting? There is a gangrene, hence there is a vasculitis, and also weakness, probably median nerve or one of the peripheral nerves got involved. She also had a history of a paranasal sinusitis. There was no history of asthma. Why the clinician is asking the history of asthma? To look for the possibility of a Church-Strauss vasculitis, but there is no history of asthma. No history of parasitic infestation. Another important close mimicker of vasculitis, you have to be doubly sure. No history of smoking. She has conjunctival pallor, there is a gangrene, palpable purpura on clinical examination, and the provisional diagnosis was that she is having a systemic vasculitic syndrome. But on blood examination, the LFT and the urea creatinine electrolytes were all normal, but the urinalysis is showing the presence of a 3+ proteinuria with the presence of hematuria is what is being clearly found. When a high resolution CT scan of her chest, because she suspected to have vasculitis, was done, there are a lot of bilateral ground glass opacities which were discovered. When the open lung biopsy was done, there is a presence of a lot of leukocytoclastic vasculitis with a lot of granuloma formation. The patient was treated with prednisolone, and there is a marked radiological improvement at a later point of time, and she is a classical case of the Church-Strauss syndrome. Though there was no asthmatic episode, the biopsy has proven that there is leukocytoclastic vasculitis involving the lung is the typical presentation. So that's the reason the American College of Rheumatology has given certain criteria before you label the diagnosis as Church-Strauss syndrome, one of the options given to you. The presence of the asthma, eosinophilia, paranasal sinusitis, with the presence of the infiltrates on the chest radiograph with the mononeuritis multiplex like clinical picture, the patient, at least 4 out of the 6 criteria if they are there, he is called a case of Church-Strauss syndrome, is what I want to underscore to all of you. So now between Church-Strauss and polyarteritis nodosa, to which of the 2 options you want to vote for, doctor? So in this case, there is no history of any fever. One of the American College criteria which were there was no asthma, there is no eosinophilia, no paranasal sinusitis, no pulmonary infiltrates. So at least 4 out of the 6, only 1 out of the 6 is there, that is the mononeuritis multiplex like picture. But even there are only paresthesias. That is the reason we shall consider in this given case polyarteritis nodosa as the major possibility. That's how you reach the diagnosis. Anybody would like to champion the possibility of systemic lupus erythematosus in her given case. But SLE will have once more another criteria are given to the SLE. But remember doctor, do we require all the criteria to be there in a given patient before we label the diagnosis and start the treatment? One of our eminent professors used to say, criteria are for the epidemiologist, patient is for a clinician. So there is a reason only alopecia is there, you are highly suspecting possibility of SLE with alopecia and oral ulcers. You have to closely follow up. Just because criteria is not there, I don't want to see the patient for next 1 year. If you are very dogmatic about your criteria, patient will finally come out one day with florid renal failure of the SLE to you. So there is a reason you must be doubly sure. Criteria are for the epidemiologist, patient is for the clinician is what need to be remembered.